Well, hello, everybody. My name is Ira Kirschenbaum. I am the editor-in-chief of the Journal for Orthopedic Experience and Innovation. Tonight, we have a superb panel and an excellent topic. The topic tonight is augmented reality in the operating room, a new era for shoulder arthroplasty. I'd like to introduce our panel. But first, I'd like to say a big shout out to Medacta, who sponsored tonight's get together here at Joey. Um, let's go around the room and we'll start with Dr. Cox. Introduce yourself.
Yeah, I'm Wes Cox. I'm in practice in Fayetteville, Arkansas. Just do shoulder and a little bit of elbow, and I've been part of the augmented reality effort for 4 years, I guess, almost five now. So it's exciting stuff. Appreciate the opportunity.
Great, and thank you for coming. John, introduce yourself, please.
Hi, I'm John Bell. I have practice up in Hanover, New Hampshire at Dartmouth, and I'm a shoulder and elbow surgeon also. Been working with augmented reality now for about 4 years, 4 or 5 years, and it's been a real positive change for my practice.
That's that's great. And we have Dr. Dilella call.
Yes, hi, I'm Dr. Carl Dilella. I'm visiting tonight from Vero Beach, Florida, virtually, and I really appreciate the opportunity to speak about next AR technology. I think it's really quite a game changer in the realm of shoulder arthroplasty. So I'm excited to discuss that topic tonight with my colleagues. Thank you for the opportunity.
All right, so we are going to start tonight with a presentation from Dr. Cox. I am going to share my screen. It'll just take a second. Hold on. Share. There we go. Let's get this up. We can see that now, Wes?
Got it.
All
So
right.
I'll request control here.
Approve.
Awesome. Well, I appreciate it. We'll get things going. The my slides are intentionally simple. I think the technology is pretty exquisite. So trying to doll it up with extra emphasis on slides and stuff. I've tried to minimize that as much as I can. Ira, I requested. Oh, there it went. Okay,
There it
cool.
is. Take it away.
Yep. Perfect. So I talk super casually. I think if the opportunity arises, I'm certainly happy to stop and say anything at any time if there's questions or whatever. If we want to take them at the end, Ira's in charge. But my task is to hit sort of high level, like what is Nexstar, why I like it, and then I'm going to show a couple of quick cases, just of sort of when I've used it and how it's helped me. So, Nexstar essentially, and I think I may have skipped a slide. There we go. Perfect. So at the end of the day, for me, it really comes down to these glasses. Like it's not a ton of hardware. I use the glasses pretty much exclusively. I know there are some that don't. They just look off the monitor, but both are options. And so big picture, what Nexstar does for me, I have a pre-planned strategy, which you can get in a variety of settings, but it's nice to have that. And then in the room, it's not intrusive at all. I mean, it's my very normal setup, and I've got a picture of that. I'm wearing the glasses, so I'll occasionally look at the screen, but really not very much. So my flow of how I do things is not really ever interrupted by this, which is, I think, unusual from a innovation standpoint. At the end of the day, what we have is a camera and a lens. One is mounted to our patient. One is mounted to every instrument that we use, and they communicate with each other, and we get the ability to get real-time feedback on every single instrument throughout the process of doing a shoulder replacement. So intra-op feedback is nice, but also the ability to change at any time. Like you can look at it and say, yeah, I know I planned this, but I'd rather do this. And you don't have to abandon anything. You can still continue to get real-time feedback, which I think is nice. And then every step being guided, especially the peripheral screws, was a really big deal for me. Sorry, I'll figure out how to work this thing in a minute. There we go. So this is my PA, Josh, and this is our normal setup. My scrub tech is just off to the left of the picture, to the right of me, and it looks no different when I'm doing Nexstar than it does when I'm doing anything else, except I have these crazy looking glasses on. The way I describe the glasses to everybody, it's kind of like a heads up display in your car. Like, yes, I can see the image, but as crazy as it sounds, when I choose not to see the image, it is not in my way at all. So I wear the glasses throughout the case. And the reason, sort of big picture on why I like it, is that I think our experience creates bias. My fellowship director in San Francisco was big about saying, hey, you may think you know how to do it and you may think you're doing it right, but your failures go somewhere else. So I don't think we always get great feedback on exactly what we're doing, even though we think we know, and we may do exactly what we intended to most of the time. There may be a decent amount of times when we're not. So sorry for the golf analogies for any non-golfers in the group, but I think it works. So hear me out. The question is, why would we change anything that's working? And it's like, Tiger changed his swing when he was on the biggest winning streak and top 10 finishes in the history of the game, because I think you can always be better. And if you're trying to be better, something that's working currently doesn't mean that you've achieved sort of peak everything. And I think we can miss. So why do we miss? Why do we miss putts? So I think sometimes we're just human and we had the right target and we failed to execute. And I think as surgeons, we can always have the perfect idea and we know exactly what we intend to do, and we just miss. And maybe by a degree, maybe by more than that, but we just miss. The second thing, and the hardest thing to tame, is sometimes you just get fooled. I mean, you've watched golfers and we've all looked at x-rays and said, what in the world? Like, we hit it exactly where we intended to. We just misread it. Like, we just didn't see it as it truly is. And so I use this analogy with my patients, so I'll share it with you. I tell my patients, hey, this is like, we have a wall and I want to hang a bunch of pictures on it, like in my bedroom at home. But like, this takes a lot of work to get it just right. Well, what if you're looking at the wall, and in this case, obviously the wall is the glenoid. I mean, this is a very small glenoid. That's a small Coker clamp, to give you an idea of how worn this little glenoid was that we were doing an Nexstar on. And so I tell my patients, like, what if I could look at the wall, and if I choose to look at sheetrock, great. But if I want to look at the studs behind it, also great. And at the same time, I'm seeing both, and not having to figure out where the studs are, knowing exactly sort of where they are and not having to modify that in any way. So it's not just cute, which is a question I was asked at one of our meetings about 6 months ago, which I thought was a great question. Is this just cute, or like, does this help us? I think it truly allows us to see what was impossible before. I mean, you just had no way of interacting essentially with the patient's CT scan. It allows you to see the map and the target and hit it. And the analogy I would use is, you don't have to wait till you see your x-ray to know if you were right or not. You literally see the read before you make the putt. And so it's the ability to still be a surgeon, use your instincts, overrule the system if you want to. It doesn't paralyze you to do exactly what it wants or keep you held in some way. It allows you to do whatever you want, but at least notifies you of the truth while you're doing that relative to the intended plan. And so you're not at risk for the bias, which is optical illusions, unseen undulations, under or over appreciating contours, and so forth. And so this is just literally a picture of the monitor from a case I did last week, where I can tell you look at this and you say, oh gosh, there's this huge osteophyte up front. But when I was looking at this patient's glenoid, that's not what it looked like. It looked like this anterior rim was the glenoid. Like it looked like it was 40 to 50 degrees retroverted, and it wasn't. It was just a huge osteophyte in the front, which fortunately Nexstar guided us through. Oh, sorry. Ira, can you go back one slide? I don't know.
Yeah, sure. I got it.
My bad. One more. Yep, that. So this is a patient of mine that we'll just show a couple of quick things. I mean, this is a very small glenoid, and the beauty of this person is they had a total chip shot reverse on the other side that I did about 13 years ago. And they came in and said, "Hey, I just want the same thing you did on the other side." Well, it was a chip shot. This is totally different. Hardly any glenoid to work with. And so use the NextStar system. And this is an intraoperative look at his glenoid. In this case, even though the picture looks the same, this is a significant amount of glenoid bone loss. It's essentially eroded all the way back to the flush part of the glenoid, and the native rim is what you're seeing that looks like an osteophyte. The NextStar system allows you to actually plan for grafts as well. So not to dive into the details, but the green on this, the light green, is actually a graft plan, which can also be guided, which is what we did here. And there's a little video of it sort of spinning around. You can sort of see anterior, all of that. The orange little halo there is what has to come off, and that lime green is what we're going to graft. I'll skip that in the interest of time. So this is the graft that was guided and taken from the humeral head. This was a primary case, so I was able to use the humeral head as the graft. This is the threaded base plate, and this is what the post-operative x-rays look like. Now, I know that I would never put the glenoid at this inclination, I don't think anyway, and I know that I would never be able to get this many screws in good bone without some guiding. If you look closely, you can see the sort of the halo effect or the shadow of that graft that's essentially from the back of the glenosphere all the way to the native glenoid. It was about a 20 millimeter graft, so you're looking at 20 millimeters of a 40 millimeter screw that's graft. And I don't know where I would have put this. I think that's the moral of the story, but I don't think I would have put it there. That's the best way to say it. And then you have these cases that we all have. This is kind of a locked big defect in the humeral head, locked sort of humeral head with a big osteophyte up front. And the ability with this one, planned for a graft, but actually used a wedge because it was a perfect fit. So I was able to use the wedge posteriorly. But so this is a case where I use NextStar. I switched to the wedge when the bone quality. Sorry, the video is a little bit wonky. But I switched to the wedge when I realized that, hey, I really just need this graft sort of one-sided. So I kind of overruled the system and used the wedge there. And then this was that case. You can see how crazy that is. There's pretty good bone up front, and then this is our wedge, and have situated it anteriorly to compensate for the bone loss. I think I'm leaving it there, and I'll hand it over. I think John, I think you're next. Is that right?
Thanks, Wes.
Yeah, you bet.
Let me
bring up yours. Okay.
okay.
Okay. There we go. Is that it? Can you see it? No.
Not yet.
Okay, I'll get it in a second. There we go. All right. Now?
Yeah, that looks great. Thanks, Ira. All right, so I'm going to talk more about the actual technical workflow and kind of how I do it. Let's see. Try to advance this. Let me get control.
I'll do it. Oh,
I
you
got it. Yeah, I got it. Sorry, trying to advance it here.
I'll move it to the arrow here. There?
Yeah. Okay.
Okay.
Great. Okay. So, getting right to the workflow. So basically, I'm getting a CT on all my pre-op total shoulder patients. You got two options. One is to burn it onto a CD and then have that uploaded to the web. The other is to have a direct image transfer, which I do through my radiology department, which has really made this pretty seamless. Then 2 to 3 days later, you get a plan back from the engineers, and I usually will review that and tweak it to some extent, although sometimes the plan is great and I just accept it. So let's see, get advance. For some reason my key's not working.
Yeah.
Okay, so this is a little video showing a plan of a case. This is a woman in her 70s who had a prior bony Bankart fracture. You can see she's retroverted maybe about 14, 15 degrees and with some inclination and a bit of a malunion. So good case for navigation. Can advance next. This is the plan that comes through. If you could just start that video. So basically, you're going to get a chance to change things here. So you can change your base plate position in terms of where the peg is, the version, the inclination, and the seating of the base plate. So I usually will go to the dicoms here and see what it looks like. In this case, I think I want to retrovert it a little bit more, so I can change that to about 10 degrees retroversion, and then I'm going to want to medialize that a little more for better seating. And so that's what we get, about 90% seating, which is great. I'm usually shooting for about 80% at least. We can optimize our screw position, and then we can see how we've changed the position. So we've gone from the pre-op, which is the shaded, to the post-op. And in this case, I wanted to lateralize a little bit more. And then lastly, we can look at the impingement. So here we're impinging on the acromion, which I don't like. So I'm going to go back and move the base plate down a couple millimeters and then check it again. And you can see now the impingement on the acromion is gone. And now we're impinging on the glenoid itself, which is better in my opinion, because there's less stress on the acromion, less likely to get a fracture post-op. So that's kind of a brief overview of the planning process. So we can advance to the next slide. Next. So you go through all of this. You can go to the next slide. So we go through all of this planning process, and then we get this is kind of our PDF, and I will print this out and put this on the wall in the operating room for quick reference. So we spend all this time planning and kind of getting things set up, and then the question is, how do we execute that? How do we replicate that plan as precisely as possible in the operating room? And so that's where computer navigation comes in. All right, next slide. So different ways of executing the plan. There is evidence that just the simple act of planning improves your accuracy. You can also get patient-specific guides, custom implants. You can use mixed reality goggles, which are kind of those big sort of VR headsets you see. But in this case, we're going to use the augmented reality navigation. And so the way this works is you basically put a tracker into the scapula through 2 small pins in the coracoid, which communicates via infrared with the camera, which is placed on whatever instrument you're currently using. Then you have the screen like Wes talked about and the glasses. Next slide. Sorry, that was the previous slide. Perfect. So this is what my setup looks like in the OR. This is me with my hood, my light, my glasses, and my N95 mask. This is from COVID era. You can see it's pretty non-obtrusive. It's not like the big headsets that kind of get bulky and get in the way. One nice feature is there is a camera in the glasses, which you can sort of see in the top there, and you can film the cases with the glasses as well. So that kind of obliviates the need for putting on a GoPro or something like that if there's something you want to capture. Next slide. So the first step is getting registered. And next slide, I'll show you a little video of how I put in the pins here and put in the tracker. So I put a Homan over the coracoid, just like with a Latarjet. The first pin is going right down the pike of the coracoid into the top of the glenoid, and that usually has great fixation. Second pin is kind of mid-coracoid, which is usually a little less fixation. Then the clamp goes on and the tracker snaps into that. We want to get that exactly parallel to the face of the glenoid and then tighten that down. And having that in the correct position makes the whole rest of the case a lot easier. Next slide.
Hold on. There we go.
Okay, great. So then the registration process goes forward. And so what we're doing is picking a bunch of points on the glenoid between the glenoid and the coracoid, which are dictated by the screen. And we kind of go through a a process, and we touch these points, and then once it agrees that it's registered, we have accuracy to within a half a millimeter and a half a degree, which is extremely good. If it doesn't register the first time, it almost always registers the second time. This is kind of how it looks in the OR. So on the left, we see the glasses image, which is superimposed there. And on the right, we see what's on the screen. So what we're trying to do here is place the K-wire. So we're going to put the dot in the center of the circle, and that sets the start point exactly according to the plan. Then we're going to line up our horizontal hash marks, which are going to give us our inclination, and then the vertical hash marks, which are going to give us the version. And so if you line all that up just right, then it's going to replicate the plan. And you can see on the right, the green is the planned guide wire position, and the blue is the actual guide wire position. So you can try to line that up as close as possible. Next slide. The next thing we're going to do is navigate the reaming depth, and this is going to help us with the seating of the implant. And so on the glasses, you can see what we call the gas gauge. And as we ream more medially, that gauge fills up to the target, which in this case is 3 millimeters. And on the screen, you can see the little circles on the bottom left. The green is the amount of seating on the plan, and the blue is how much seating we're getting with our reaming as we progress medially. Next slide. Then we're going to navigate the orientation of the base plate. So by placing the dot in the center of the circle on the glasses, we can then align the screw holes in the optimal position to get the screws into the best possible bone in the glenoid. Next slide. This is my favorite part of the case, which is navigating the screw trajectory. And so in real time on the CT images, you can see exactly where the screw is going. So you can maximize length, you can maximize bone quality. Most importantly, probably you can minimize the risk that you're placing it into the scapular spine where you might cause a stress fracture or into any other places you don't want it. Next slide. And then lastly, with the AR glasses, we can optimize the offset of the glenosphere. So these are offset glenospheres, which means part of it is going to overhang further than the other part. And so if you put the dot in the center of the circle here, you're going to have the maximal offset at the scapular pillar, which will minimize the risk of scapular notching. Next slide. So at the end of the case, you get this nice report which shows you how you did. The circle will show you the percent coverage of the base plate with the bone. You can see your inclination, retroversion, reaming depth, etc. And that can be very helpful when you go back and look at how your accuracy has been and potentially for research questions as well in the future. Because this is telling you how you actually did in the surgery, not what your plan was. All right, next slide. Okay, so here's a quick case example. This was a really difficult glenoid I had. This is a 64-year-old guy, was in a motorcycle accident, he had a bad glenoid fracture, intra-articular with displacement, was treated with ORIF at an outside hospital, but went on to develop a malunion with some intra-articular hardware and had very poor range of motion and pain. Next slide. So we decided for this to do a reverse. This is our plan. We decided to integrate a bone graft in this as well because we didn't want to over-medialize. Next slide. So in the case, we went in from the back through a limited incision and took out the plate and screws. This is a picture of the exposure with the very prominent inferior part of the glenoid and kind of punched in superior portion. And as you can see, this is not a normal looking glenoid. It's difficult to tell where the vault is behind that, as Wes was talking about. Where are the studs here? Where can we get our peg? Where can we put our screws? Next slide. So in this case, we had planned to ream about 45% of that inferior glenoid and have that touching the base plate. And then we're going to bone graft the superior 55%. And so using the NextStar, and you can see here what the tracker looks like in the patient. You can see where the pin wound up and how we reamed approximately that same amount as in the plan. Next slide. This is a picture of the bone graft on top of that reamed glenoid, and this was harvested using the Grab system, which is another Medacta product that goes along with the preoperative planner. You can see the base plate is there compressing the bone graft into the superior glenoid and the glenosphere in place as well. Next slide. So here we can see the final report. So that's exactly what we did, and that's very close to the preoperative plan in terms of the amount of reaming. And we got very good inclination of -1 and retroversion of -2, which is really close to our plan. And if you go to the next slide, we can see the x-rays. You can see, again, the shadow of the bone graft superiorly. And probably most importantly, you can see on the axillary view how the peg is really right down the center of the vault, even though there was all that deformity present. Next slide. So this is the patient at a year post-op doing well, pretty normal range of motion, not totally symmetrical, but pretty good. And most importantly, not having pain and happy with his result. That's it. Next slide. So thank you all very much. It's a real honor to be included in this this event, and happy to take any questions.
All right. We have JD Stevenson. You have a question? You want to unmute yourself and ask the question?
Yeah, hi. So first of all, thank you all for taking your time to come on here and help us out. This is a really cool technology, but with I don't know, for us, we use NextAR for knees, and there's just been increasing denials from insurance with regards to like CT scans and for the knees, and then patients saying, well, I'm not going to, we just had one 2 days ago that said, I'm denying the CT, I'm not going to get it. Curious on how to navigate that. For us, like on the Medacta side, and I think for our surgeons, like how to have that conversation. And then the second question I just posted in there is, if the program shuts off during surgery, do you have to re-register everything or start all over? Like, how does that work? So I know it's a two-part question, but really interested in the answer. Thank you.
Yeah, so with the first question, so shoulders and knees are definitely different in this regard. CT scanning pre-op for shoulder replacements is pretty close to the standard of care at this point. I think I wouldn't say it is the standard of care because some surgeons still do a lot of non-planned surgery, but planning is widespread. And I have not had problems getting CT scans covered for preoperative planning purposes for shoulders. It doesn't totally surprise me that you're seeing that with knees, just because that's a relatively new preoperative study. And it probably, with shoulders, there's been, a lot of published evidence that preoperative planning improves implant positioning and potentially outcomes as well. And I'm not sure that type of literature exists for knees yet. I'm not a knee surgeon, so I could be wrong about that, though.
Okay, great. Thank you so much.
And
Same for me. Yeah, my experience has been the exact same. I mean, it's and also I have no idea what's in the knee literature because I don't ever look at it. But I have not had any issues getting CT scans with the Medacta protocol when I needed them.
Agree. Same here in Florida, mostly Medicare population, but no real denials on preoperative CT scans. To address your second question, JD, thankfully, I've never had the unit shut off, so I've never actually encountered that situation. Wes or John, has that ever happened to you? Do you have to re-register if the unit shuts off? Never happened to me.
I would say it's pretty rare for kind of technical glitches like that, but occasionally you will see, you might lose communication between the glasses and the computer or the glasses and the tracker or something like that. And you do not lose the registration. It's just a matter of reestablishing the Bluetooth link again, which just takes a few seconds.
Yep, same. The only time I've ever seen that happen is in NextStar labs when someone's doing a NextStar like 12 to 15 feet from us, and the camera and the lenses get confused on what they're looking at. In the operating room, I've never seen it. But a follow-up sort of question you didn't ask also is that if you drop, like if the camera drops when your scrub tech's exchanging it between whatever, once you're registered, you're registered. So they can open a new camera and you don't have to redo any registration. You just pick up right where you left off.
Awesome. Thank you guys so much. Appreciate it.
Yeah, you bet.
All right. So we have the pleasure and the honor at this point in time to have a video from Dr. Zumstein I'm gonna queue up that video. Hold on a second. Just queue up the video. I got that. Share my screen. Okay. There we go. Here it is. All right. This is a pleasure. Dr. Zumstein is from Bern, Switzerland. He wanted to get some sleep tonight, or he's working during the day. So, however you look at it, we're having him here due to the power of Zoom. So I'm going to play this video, which is better to execute the plan.
So, hi, my dear friends. Unfortunately, I cannot join you virtually because it's in the middle of the night, but I'm happy to share you my thoughts regarding planning and execution of the planning. These are my disclosures, which are for sure relevant to this talk. So Benjamin Franklin already told us, if we do not plan, then we prepare ourselves to fail. And this is key in surgical procedures. So that's why I think we should plan every surgery, especially arthroplasties, because the imposition of the implants matter in order to avoid complications and achieve better performance and functional outcomes. In terms of the reverse, I think for the positioning, it's absolutely key to discuss and think about relative lateralization as well as distalization, the filling ratio, as well as postures. I think we all agree that his shoulder on the left-hand side has not the same size as her shoulder. So that's why I think we should meticulously calculate every prosthesis individually. We should know the humeral lateral offset between the pivot point and the shaft from A to C, as you see on the right-hand side, as well as the glenoid lateral offset from C to E. And they take these both parameters into account where we want to position our prosthesis. Because there is a clear trend towards anatomic reverses, meaning to access the same medial lateral point. In terms of head neck shaft angle, clear preferable 145 over all the others in order to have everything, including abduction. There is a clinical evidence also to have more range of motion with the 145. However, the implant positioning is key, so you can change the head neck shaft angle easily by implanting, not perfectly. In terms of the glenoid distalization as well as lateralization, at least by 2 or by 4 millimeters respectively is key in order to achieve the best range of motion. And again, if we achieve this positioning, we can stay at the same medial lateral point to fix always the remaining subscap and have the same tension of the remaining posterior rotator cuff. This is not only my thoughts, these are the data of also many other authors, as you might see below. In terms of the filling ratio, stay always below 70% in order to provide less stress shielding. And in terms of the posture, there is a big discussion regarding positioning the humeral component more in retrotorsion if you have a type C compared to a type A. So if we want to execute the plan, then we can transfer our planning into the surgical procedure, either using PSIs, navigation, with or without augmented or mixed reality. I will just discuss that later and the last 2 points and discuss about the experimental precision. We've done that study, cadaveric study, 3D planning, and assess all 3 parameters: inclination, reversion, entry point depth, and rotation of the glenoid component. And we do not just measure the K-wire, we've done an overlay of both pre and post-operatively CT scan, including the planning, and show the precision. And interestingly, we were always below 2 degrees and 2 millimeters for all the 5 parameters that we measure. This has been confirmed also by other authors, especially the big difference is that we assess the component by an overlay of the CT scan preoperatively and postoperatively, compared to the others where they just measure the positioning of the KUI, where we can cheat the KUI positioning by 7 degrees in all different directions. In terms of the clinical position, we've done this proof of concept study, 26 patients. We had to exclude a couple of them at the beginning, and we want to exclude them because we have issues with the system and we have fractures of the coracoid. But then the remaining 17 patients, we were able to include them, standard including criteria for a reverse. From plan to intraoperatively, we were always below 2 degrees or 2 millimeters, except of the reaming depth. As we changed the reaming depth frequently during the surgical procedure, Alex and I, we were not as precise as we thought. This has been confirmed also by other authors. In terms of the difference between intra to post-operatively, we were always, except for retroversion, below 2 degrees and 2 millimeters. So this has been confirmed again by many other authors, and there is a clear trend towards significant better odds ratio for navigation, for retroversion and inclination. And with navigation, you significantly position the component and with using an augmented glenoid component or a bony augmentation, you have a better screw placement, longer screw hold, but you have additional surgical times of 12 minutes. So I think we should plan always meticulously, transfer our plan into the surgical procedure. We are experimentally precise below 2 degrees and 2 millimeters for both for all the components in the glenoid, except retroversion in a clinical setup. Again, with navigation, we select significantly more frequently augmented glenoid components or use bony augmentation. We have a better screw placement, longer screw hold, but additionally 12 minutes. And we do not know if this has a significant impact on the clinical difference. I think both in anatomics and reverses for both the humeral side as well as the glenoid side, what you guys in US can already do, navigation is one of the options in the future. And I thank you very much for your attention.
All right, that was great. I think next topic session we're going to have in Switzerland, and everyone is going to get to go on a grant for 2 weeks to Switzerland just to hear Dr. Zumstein. So some comments on what he talked about? We have that from the panelists. John, what do you think?
Yeah, I was going to say, I was sorry, I was muted.
Yeah.
That's incredibly good data. The original kind of quote that we were given was it's a 0.5 millimeter and 0.5 degree, but now that we have this clinical data, it's especially helpful to know that we're within 2 degrees and of exactly what we planned. And to be honest, 2 degrees probably doesn't matter one way or the other, but it's very close. So it's very reassuring to know you're within that degree of accuracy before you leave the OR.
Excellent. Any other comments before we move on? All right. I am going to share the next talk, which is Dr. Dilella. Right here. We got that up for your call?
I do, yes.
All right. Nice clinic. Yeah.
Thank you so much. So I wanted to say thank you to Dr. Kirschenbaum and the journal team for allowing me to participate in tonight's webinar. I was tasked with discussing the previous topics of NextAR with specific use in the surgery center. So this first slide here is a picture of my surgery center. It's Grove Place in Vero Beach, Florida. It is a two-room center, but we still are able to do quite a bit of orthopedic surgery there, including total knees, total hips, and in my realm of orthopedics, total shoulders. Could we go to the next slide, please? Okay, so this has been discussed, obviously, again, just to reemphasize the glenoid base plate position, really critical in the outcome for the total shoulder replacement and for the patients. The accurate positioning, clearly still a challenge, because as Wes and my colleague John and Matthias already discussed, sometimes you can be fooled, and having the addition of some technology that can really help you with accuracy is really critical. And for some shoulder surgeons out there, they're doing smaller volumes. When they see things that perhaps they're not used to, the use of this technology can be really critical in their hands. Next slide, please. So I think this was already, again, discussed, but the technology that Medacta innovated to handle some of those issues are the tracker system of registering the patient's glenoid to the preoperative plan, matching it to the next AR unit, and then using intraoperative feedback with either the glasses or the screen, as you see here. And next slide, please. So I'll kind of jump through this because I think it's been touched on by some of my colleagues already, but the registration, it's evolved a little bit, where it began with actually 15 points on each of the coracoid and the glenoid bony anatomy. It's been reduced to doing 6 initial points on the glenoid vault, then a total of 26 by incorporating the coracoid tip or base, and then other points around the glenoid face to register and match the preoperative CT scan and plan to the intraoperative situation. Next slide. Obviously, then we start with K-wire positioning, can be done very accurately, as already discussed, within 2 millimeters and 2 degrees of accuracy. Next slide, please. Reaming can be controlled and watched with intraoperative feedback, very helpful to the surgeon intraoperatively. Next slide, please. And central drill for either the peg or whichever base plate you're using. Again, match the patient's preoperative plan. Next slide, please. Base plate insertion, I think this has already been touched on, so that can be matched to the plan, and positioning the offset in the right position on the glenoid to avoid notching, very critical. Next slide, please. This, I think my colleagues have touched on already, because it's really the part that I enjoy doing the most, because where I think I've done enough of these to know where the superior and inferior screws should go, and the anterior posterior ones, I'm certainly fooled sometimes. So the use of this technology here is really critical, I think, to me. And what's nice is being able to adjust, as I'll show maybe in an upcoming slide here, screw length, position, trajectory, really critical to getting those screws in good bone and achieving good rigid fixation for long-term success of the implant. Next slide, please. Here's the glenosphere insertion, again, to maximize the offset inferiorly and posteriorly to avoid notching. Next slide, please. There's a post-operative report. This has already been discussed to see actually how you did the surgery at the conclusion, which is nice surgeon feedback to see just exactly what was done and performed. Next slide, please. So in my realm, I'm talking in a surgery center, so there's certainly some pressure on how to do it on an outpatient basis. We're not equipped in our 2-room center there in the picture that I showed you to keep those patients overnight. So I have to give quite a bit of credit to my anesthesia colleague who's quite skilled. I've worked with now for 5 years. In this center, we do have patient criteria that you see there: age less than 80, no major cardiac pulmonary comorbidities, hemoglobin criteria, and A1C criteria less than 7%. The real biggies are when we get the patient into the surgery center, how do we do it? So the picture there, the interscalene block, really quite critical to make the patient comfortable after the operation. We've expanded to now using Exparel, which is liposomal bupivacaine. I'm sure many on the webinar tonight are familiar with that. It is now approved, and we're able to do those with interscalene regional blocks for the shoulder, which is really quite a game changer for the pain relief after the operation. The protocol that I use, the patients preload with Celebrex the night before, 200 milligrams, and then continue that twice daily for the first 2 weeks after the operation. If they're contraindicated because of an anticoagulant, then Tylenol used around the clock 3 times daily, 650 milligrams. I do add a muscle relaxant. Flexeril is my choice. Soma can also be used at night because of the somnolent effect, and also for any spasms that the patient may experience after the operation. obviously ice application, and then hydrocodone or Norco for breakthrough pain if necessary. Next slide, please. The other direction, perhaps, Ira, please.
Yeah, there we go.
Okay, so quick case example here. Patient of mine, 78 years old, met the criteria due in the surgery center. She was rheumatoid. Don't have really a great axillary lateral there, so I really wanted to plan this one carefully. I'll go to the next slide. So here's the pre-op plan. You've kind of seen these again here before tonight, but if you focus on the picture there on the right, I wouldn't say that I'm exactly too convinced that I want to have that inferior base plate screw exactly where that plan is. So really quite critical to get into the operation live and being able to adjust that position, because on the preoperative plan, I wouldn't say I love that position right there. Let's see the next slide, please. This is just the other part of the plan highlighted a little bit better. I'd say that that inferior screw is probably not the best position. So next slide. Here's what I really like to emphasize is really the team approach. Here we have one of my favorites on the left there from Dr. Sanjeev Patel, who standing next to the next AR unit to help with registration, and certainly your rep, who's really going to be critical and perhaps introducing this into a place where you have not done one before. So getting your team on board, and then my very skilled helpers there. We're going to be changing the cameras, as Wes and John discussed in their talks, in between almost every step that we showed in these slides. Back table people are going to be helping you do that. And when you involve them in the process, you're going to make your operation go a lot smoother, and you'll be a lot happier at the end of your OR day. So I really like to emphasize that team approach when you're bringing this type of technology into a new arena. Next slide, please. This is my personal OR setup. So I have an assistant standing there to my left, B chair position. The arm is over a padded Mayo stand. And I like to position the unit at the foot of the patient on the opposite side of the table. Have used the glasses as Wes has discussed in his talk, but sometimes I find that if I'm not looking directly at perhaps the blue drape, if it's a little bit lighter, like you see in the screen there, sometimes I have a little bit of difficulty visualizing it best through the glasses. So just my personal preference, I find looking over at the screen just a little bit more helpful for me personally. Next slide, please. Here's again just a different perspective. So I think John already showed the pin placement. It's something that he showed me in the lab, which is very helpful. If you saw in John's video, he's placing his finger down on the coracoid base. So kind of triangulating his hand with the pin into his finger that's in the patient on the coracoid base. Very helpful for placing that first pin where you really want to have good fixation. Admittedly, as John said, second pin a little bit further out on the coracoid sometimes doesn't always have the best purchase, but that first one very critical. And before I tighten down the tracker that's attached to the coracoid, I actually hold the pin and the second tracker and make sure that at least the two trackers can see each other or communicate before I tighten down the tracker to the pins. Next slide, please. Here again is the emphasis on the screw placement, as my colleagues have discussed, and I really love Wes's analogy of being able to see behind the wall, because in this scenario, this patient had quite a narrow glenoid, a vault and pillar where I'm able to change the sizes. That was a 30 that I chose there, which I felt was bicortical and well positioned right down the center of the pillar there. So I would say, doing that blindly or just with my experience, I would sometimes miss, but having the next AR technology, really critical to know that screw length and that position. Next slide, please, Aaron. Here's the postoperative radiograph. It shows a standard stem and a rheumatoid. And on the right, I think that screw, at least the superior one right at the base of the coracoid where we have good, strong bone, the technology really helped me here. Next slide, please. And of course, despite the number of cases that we do and experience and seeing lots of glenoids, certainly we're all sometimes have a bad day. So using this technology can really minimize or potentially avoid those completely. Next slide, please. Thank you so much for your attention. I think we'll take questions, or if anyone from the crowd has anything they want to discuss.
Yeah, I want to ask Wes first a question that was on my mind. Would you say Nexstar is useful in all cases or just really bad deformity? Oh, is Wes around? All right.
Good.
All right.
He's on mute. I can see him. Can you
Oh, he's on
unmute him?
mute. Wes, unmute. Unmute. I can't unmute him. You got to unmute Wes. Yes, unmute.
I could take that one, Ira.
All right, take it away.
So definitely extremely helpful for bad deformity cases. I actually think it's helpful for all cases for a couple of reasons. First of all, you have to there is a bit of a learning curve to getting used to it and gaining trust with the system. And if you do it on easier cases early, then when the bad deformity cases come along, it's a lot easier to deal with it. The other thing is, I do think there's going to be a big advantage to having this data of where we're putting implants in the future. And so, I think in the world of artificial intelligence and we basically now have the ability to know exactly where we've put the implants at the end of the case, probably with more precision than we could get just by getting a post-op X-ray or a post-op CT. And if we combine that sort of data on how we've placed the implants with patient outcomes and range of motion and, PROMs and stuff like that, complication rates, AI may be able to help us understand what positions of implants are optimal for certain types of patients. Obviously that's far in the future, but I think having data like this can only be helpful.
Wes, you're unmuted now.
I am. That took a little bit of effort. I appreciate your patience. So, yeah, I think a couple things, and including what John just said. Number one, I think we have a better understanding of where we're actually putting the implants than we ever did. I think we've always had a really good understanding of where we intended to put them, but having a clear picture of exactly where we put it relative to their anatomy, not relative to some other obtuse thing, is new. I mean, it's and to the spirit of the initial question when I couldn't get unmuted, the hardest case that I've ever done was the case right after the first Nexstar that I ever did, when I realized what minute movements did for retroversion and inclination. I mean, it was a little bit frightening and maybe eye-opening to say that a little bit of hand tension moved you from 5 degrees to 0 degrees or 10 degrees to neutral in retroversion. And so I don't know that there's a perfect case to do it on initially, but I think that to trust it initially, it's easier to do it on less deformed cases. I think that now I trust it implicitly. I mean, it's proved me wrong and it correct multiple times. And others may have that same experience, but I think starting with something that has less deformity so that you can sort of see it as is probably a little bit more helpful. But if you tackle a first case that's a disaster, I would default to trust the system more than I would trust your eyes.
I want to ask the whole panel, what are your thoughts on robotics in shoulders now that you've been using this? What are some thoughts? Maybe let's start with Carl. Some thoughts on robotics in shoulders.
Sure, Ira. I guess I'm going to be a little bit biased, perhaps, on the panel because, like my colleagues here, I've had such great success and feedback from the augmented reality system that I've used. Admittedly, I've only used the Medacta one, but I like the ability for my hands to be able to move it and to have the screen or perhaps the glasses feedback without, say, the haptics of, say, a Mako type that's using a burr, et cetera. I prefer, maybe as my colleagues do, to have those instruments in my hands for the tactile feedback.
Sure. John?
Yeah, I think robots also achieve sort of the same goal, which is to precisely execute the plan that you've taken the time to make. I think in shoulder, it may be a little bit more difficult because, with a knee, for example, there's a lot of real estate where, people can stand on either side of the table and still have access to the knee. Whereas in the shoulder, there's really not a lot of places where the surgeon can stand and still see the glenoid well. And the robot has to occupy a fair amount of that space. So I think that'll be a challenge with robots with shoulder. Um, and like Carl said, I really like the ability to, and Wes also, I like the ability to be able to just kind of adjust in real time. If I say, oh, I just want to go a couple more millimeters this way or a couple more degrees this way, nothing's pushing my hand back towards the plan. I just see where I am and I can fire the pin wherever I want to, and it just tells me where I fired it. So I like that freedom, and I also I do worry a little bit about the logistics and the kind of the ergonomics of the case with a giant robot occupying a footprint on the floor.
Yeah, Wes, a few comments
Yeah.
on that?
Yeah, same. I think that number one, I think this is a start to finish platform, which is different than anything else that's on the market. Not better or worse, just different. It's the only thing that we can start the case and finish the case with every step using Nexstar. I think the robots that, I mean, I certainly trust robots to get things right. I think most of the cars we drive are probably mostly assembled by robots these days. But we're, we're not cars. And sometimes things are a little bit different than maybe you planned, or maybe you are reaming a osteophyte and you get a glenoid fracture and you still want to see where the screw goes. There's times where we have to pivot and change, and it's nice to be able to do that and still have guidance, even if you're deviating from your plan. To have guidance and information, I think, is unique to an AR platform.
One aspect of innovation I often ask about is if this came out first before anyone did any type of shoulder replacement, would you ever freehand the shoulder? Would
Huh.
you, if this came out first?
It is, Ira, that is a fabulous question. I don't know if you were asking me, but I'll jump in.
Yeah.
I think it is, um, it's unbelievable how minute the feel of your hand position is relative to degrees of inclination and retroversion, which I think we will learn more and more about what those critical numbers look like. I mean, right now, all we know is where we're putting it. We still haven't been able to use the data to see where should we be putting it. How do we get people scratching the back of their neck with internal rotation and guaranteeing this and that and the other? But I mean, it is it is overwhelming. I may be the right word when you first see how we talk about. Do you like it at 5 degrees or 10 degrees? And I don't know that we know what that is. I mean, it's like asking a pitcher to throw 78 instead of 84. Like, I don't know that they know how to do that if neither is their top end or low end. You know.
Interesting. Interesting.
Yeah. I mean, I would just say when I do a revision, for example, it's hard to always get a plan and the ability to use navigation for revisions because of the metal in the glenoid. And when I'm doing those, I'm just wishing that I had this because it's so hard to
Right.
tell with the precision that I'm used to now from using this type of navigation where I am. I did a lot of cases before navigation, so I kind of have that experience, but it's it definitely feels like you got one eye shut when you're doing a revision without navigation, at least for me.
There's a question from Ben Van Neville. You want to ask your question if you're available, Ben? Unmute. I'll ask it for him in the meantime. How many cases would the panel say it takes to become proficient with the system, or efficient and proficient with the system? How many cases? Carl, you want to start off with that? How many cases?
Sure. I think probably 5 cases is probably reasonable to get your workflow down of the registration. I mean, admittedly, there's a couple in the beginning where what didn't have the points mapped right, and I may have redone a registration. But after doing it probably 5 times, I think the workflow got pretty refined for me that I could do it first registration and get used to the workflow of changing out the trackers to the instruments with my team that I showed there. So my estimate would be 5 cases.
This is Ben here. If you were a new user to Medacta and using NextAR, would you still say it would be 5 cases?
I'm sorry, can you repeat that? A new user completely to Next?
To Medacta and NextAR.
Ooh, boy, tougher question. So new user to the shoulder system and NextAR. Ooh. Yeah, probably. I think probably 5 cases. I mean, there are also some criteria. I mean, the Medacta team is really big on the education, Ben. So a new user to the shoulder system, they really love you to have a lab and implant the whole, know all the instruments in a lab, or work perhaps with one of the panelists that you see tonight, and really get educated on the system. And then also what we're now teaching the lab is both. So we usually have a designated station at one of the Medacta more labs that are held throughout the calendar year to do cadaver labs, learning the system and NextAR at the same time. So, but the short answer to your question, all right, maybe 10 cases to do the NextAR system and the new shoulder system all at once.
I love it. It's an evolving answer.
Yeah. Kevin
I love it.
Plancher, you have a question or a comment? Dr.
I
Plancher?
do. First of all, good evening. To have John, Carl, and Wes, experienced surgeons, this question is not centered over Medacta, which I'm fascinated and I love it and to try. But I guess if Gilles Walsh was able to do all these reverses and has long-term outcomes, does any of this matter? And so is this been now something just to let surgeons say, I'm not making enough money, so maybe it's time for me to start to do some shoulders in my life? And if you're not fellowship trained, you could do it right away. And so I guess it's a general comment on the whole industry of it. I actually think this is fascinating, and I love Medacta for doing this and the AR. I believe all these three gentlemen. I just have a problem with total shoulders. You either know how to do it, you don't. And if you don't, you shouldn't be in the industry doing them. And we all shouldn't be doing shoulders. It should be left to those people that focused on shoulders in life. So I'm wondering, if Gilles was able to do it, why can't we obtain the same kind of expertise over time?
Who wants to take that one?
Kevin, that's awesome. Can I jump in?
Yeah.
Kevin, that's an awesome question. So I have told in a couple of different labs a story about this guy that I did a reverse on, different system, and his inclination was terrible. I mean, like, I had probably 10 degrees of superior inclination, like superior tilt, and I was using a system that had built-in 10, I was using the DJO system at the time. When I went back and did his other shoulder, his contralateral shoulder, I intentionally inferiorly tilted it maybe 20 degrees, and I get his post-op x-rays and it's neutral. And at this stage, I had probably done, I don't know. I hadn't done 10,000. I'd done probably 3,000 shoulder replacements at that time.
Right. A lot.
And I was wrong. I was flat out wrong on what I saw versus what I thought I saw relative to some part of his anatomy. And I think, if you look at complication rates and this is not this is only a compliment to Gilles. Like, this is only an improvement of what he bettered for all of us, right? Like, understanding how do we get more internal rotations? How do we raise our expectations? How do we say, I hope that people with bilateral reverses can swim freestyle for 1.5 miles every morning versus out of pain and 130 degrees of forward elevation. I think as the demand and the expectation of our patients change, these 5-10 degrees here or there are starting to matter. I don't know that we know clearly which direction they matter most in yet, but I think this is helping us get there a little bit. My opinion.
No, I agree. It's interesting, and whether it's, as Ira said, robotic, whether it's going to be AR, but the point is all these devices will help you. I just don't want people without visiting others like we all did. I'm sure you did it, Wes. I'm sure
Yeah.
John did it. I did it. Visit others before you take these things on, because it's a human life that
Agreed.
you're helping.
Agreed.
So this is a great session. As I often like to say, this is the fastest hour in orthopedics, the Joey hour. I just want to go around the horn and just some final comments possibly from each of our panelists. Wes, you want to just start off a couple of final comments?
I probably spoke more than people wanted me to, but you've got, I think all of us are open to further communication. I think that this is the future. I mean, it's just kind of being more accurate more often. I don't know how else to say it. More accurate more often is kind of how I tell my patients. And but hey, we're all still learning, so I'm open for any input, advice, suggestions. It's all helpful. I appreciate the opportunity tonight.
Great. Carl, some final comments?
Yeah, I will. Thank you again for the opportunity. I really appreciate it. And I think one of my comments, sort of to dovetail with Wes, if people want to start using the technology or start using the system, I mean, Medacta #1 is very open to the education. It's really one of the pillars of the company that they really stress, and that's not just lip service. They really stand behind that. So I would just emphasize anyone listening that wants to try it, come to a lab, contact one of the panelists. I mean, when I go to the labs and I teach sometimes with Wes and John, I see sometimes at their station things that I'm learning when I go to see those labs. So it's really helpful doing it on a cadaver and seeing, different ways that people do it. I really pick up little tips. Maybe the panelists do too when they go to a lab, and we sometimes collaborate and teach people how to do it. It's really helpful. So I'm excited about the technology. Just in conclusion, I think it's really helpful, and it's going to really be a game changer as we follow this data.
Excellent. And John, you want to bring us home for tonight?
Yeah, just Ira, thanks so much for putting this all together. This is an awesome forum. I'm certainly going to be tuning into a lot more of these in the future. It's exciting to get this out there. I feel really strongly that this is a advance in technology that's going to ultimately help patients. And I think as we get more research done and kind of show the advantages, it'll be great. But otherwise, I agree with Wes and Carl, and it's been a really fun night.
Great. And I want to thank everyone, especially the panelists, Medacta, the Joey team, and all the participants, and wish everybody a good night.